You've painted your nails with expensive antifungal liquids for 6 months, and the fungus is still there. Your doctor says the only other option is a pill that could permanently damage your liver. What if I told you that treating the top of the nail is the exact reason you are failing? Today, we are exposing. This video is for educational purposes only. If you are diabetic, have neuropathy, or a compromised immune system, do not attempt to self-treat or aggressively file your own nails, as this can lead to severe bacterial infections. Always consult with a podiatrist or healthcare provider. I want you to hear something clearly before we go any further. If you have been dealing with nail fungus for months or even years, you are not lazy, you are not dirty, and you are not failing because you didn't try hard enough. Nail fungus is frustrating precisely because it lives inside a structure that is built to defend itself, and that makes treatment slow, stubborn, and emotionally exhausting. This is a condition that can linger for a long time, and standard treatments often feel painfully underwhelming. Now let me validate the part nobody says out loud. People with chronic toenail fungus often become experts at hiding their feet. They stop wearing sandals. They avoid pools, beaches, locker rooms, and even intimacy, because every glance at their toes feels like a reminder that nothing has worked. And when they finally ask for help, they are often handed one of two extremes. A pained-on solution that promises a lot but barely reaches the real problem, or an oral medication that feels so serious it makes people wonder whether the cure is worse than the condition. That emotional whiplash is real. It is not in your head. It is the experience of millions of people trying to solve a deep biological problem with shallow tools. Here is the setup for the entire masterclass. Nail fungus is not just a surface stain. It is a biological invasion that can persist under a dense protective nail plate. When treatment is aimed only at the visible top layer, it can feel like you are spraying perfume at a fire. Some topical antifungal solutions do have measurable penetration, but the nail unit is still a barrier, which is one reason treatment remains challenging and cure rates are often modest. That is why so many people spend months applying something faithfully and still see no meaningful change. The problem is not their discipline. The problem is the route of delivery. And then there is the other extreme, the oral pill. Terbinafine is a real prescription antifungal, and for toenail fungus it is commonly taken for 12 weeks. But the FDA labeling warns that liver failure, sometimes leading to transplant or death, has occurred, and it advises pre-treatment liver testing. The American Academy of Dermatology also notes that liver damage is a possible, though rare, side effect and that patients need liver function monitoring. So for many people, the emotional equation becomes brutal. Keep buying topical products that seem too weak, or take a systemic drug that requires serious medical oversight. That is exactly why so many patients feel trapped. So in this opening chapter, I want you to hold one idea in your mind. The issue is not just fungus versus medicine. The issue is delivery. If the treatment cannot meaningfully get where the infection lives, people are left with disappointment on one side and fear on the other. And that is why this video matters. We are not here to shame topical care. We are not here to glorify pills. We are here to understand the biology honestly, so the next chapter makes sense when we break down the keratin shield, the nail bed, and why the surface is not the whole story. Let's start with the part that changes everything. The nail is not soft skin. It is a compact keratin barrier, and the hard, densely packed nail plate is designed to block outside substances. That is why onychomycosis is so stubborn. The infected nail unit is protected by a structure that resists diffusion, so a liquid can look active on the surface and still fail to deliver enough medicine where it needs to go. This is the keratin shield, and it explains the emotional mystery patients feel every day. They apply the drop, the lacquer, the brush-on formula, and nothing seems to change fast enough. Dermatology guidance says topical medications kill fungi on the surface of the nail, and clinicians may file the nail surface to help the medicine penetrate more deeply. That is a quiet admission of the problem. The barrier is real. Even the best prescribed topicals are working against geometry. The AAD notes that efinaconazole and tavaborole must be used daily for about 48 weeks, because nails grow slowly and treatment takes time. Reviews of onychomycosis also describe topical therapy as less effective than oral therapy, largely because of poor nail penetration, and they note that relapse is still common. This is why people often buy the wrong product for the wrong target. The AAD is explicit that non-prescription terbinafine cream can treat fungal skin infections, but it cannot treat nails because the medication must penetrate the nail plate. In other words, a cream can be excellent for athlete's foot and still be the wrong tool for toenail fungus. And for anyone with diabetes, neuropathy, or reduced sensation, this is where safety comes first. Foot injuries can be harder to feel and harder to heal, so nail care should stay conservative and be guided by a clinician or podiatrist rather than aggressive home filing. The point is not to be fearless. The point is to be precise. Now that you see the barrier, the next question is obvious. How do you get anything through it without turning to a body-wide drug? That is where the next chapter begins. Now we reach the part most people are quietly afraid of. When nail fungus has resisted topical treatment, many clinicians escalate to oral terbinafine, a prescription antifungal taken by mouth. For toenail onychomycosis, the FDA label lists the usual course as one 250 mg tablet daily for 12 weeks. That may sound simple, but the simplicity is deceptive, because this is no longer a local treatment. This is a whole body drug meant to clear a problem in one small part of the body. That is the real trade-off. The FDA says liver function tests should be performed before terbinafine is prescribed, and periodic monitoring is recommended during treatment. The American Academy of Dermatology says the same thing in plain language. Check the liver before starting, repeat testing during treatment, and remember that liver damage is a possible, though rare, side effect. So yes, this medication is legitimate. It is also not casual. Here is why so many patients feel trapped. They are being asked to accept a body-wide risk for a localized fungal infection. The FDA warning is unusually serious for good reason. It states that cases of liver failure, some leading to liver transplant or death, have occurred in people taking terbinafine, including patients with and without pre-existing liver disease. That is why doctors do not treat this pill as a throwaway prescription. They treat it as a monitored decision. Liver tox, the NIH drug-induced liver injury reference, is equally direct. Oral terbinafine has been clearly linked to rare instances of acute liver injury that can be severe and sometimes fatal. It notes that clinically apparent liver injury is rare, but when it happens, it often appears within the first 6 weeks of therapy. In other words, the danger is uncommon, but it is real enough that the medical system has to respect it. And the symptoms matter. The FDA instructs patients to report persistent nausea, loss of appetite, fatigue, vomiting, right upper abdominal pain, jaundice, dark urine, or pale stools, and to stop the medication and get liver function checked immediately if those signs appear. This is not the language of a harmless vitamin. This is the language of a drug that can help, but only when the risk is understood and watched carefully. So the dark truth is not that terbinafine is bad. The dark truth is that many people are handed a powerful internal medication before they have ever been taught how stubborn the nail barrier really is. Once you understand that mismatch, the fear makes sense. You are not irrational for hesitating. You are responding to a very real trade-off. A strong systemic medicine, a monitored liver warning, and a condition that began in a tiny place at the edge of the toe. Here is the breakthrough idea. The goal is not to attack the nail with more force. The goal is to improve delivery. Dermatology guidance is clear that thinning the nail with professional debridement can make treatment more effective, because reducing thickness helps medication work better. In some cases, tiny microholes can even help medicine move beneath the nail plate. That tells us something important. The nail barrier is the obstacle, so the solution has to respect the barrier instead of pretending it is not there. And this is where the conversation changes for people who want a non-systemic approach. Topical antifungal care is not meaningless. It is limited by penetration. Reviews of onychomycosis repeatedly note that topical therapies have fewer side effects but are less effective than oral treatment, largely because they have difficulty getting through the nail plate. So the biological question becomes, how do you keep something in contact with the nail long enough, and in a form that has a chance of reaching the infected unit beneath it? That is why botanical protocols get attention. Not because they are magical, but because they are meant to be local. Tea tree oil has been studied in small trials, but the American Academy of Dermatology is careful here. The studies are small, and we still do not know enough about effectiveness or side effects. That matters. It means a botanical blend may be considered an adjunct, not a miracle. But for people trying to avoid a whole-body drug, the appeal is understandable. Local support, lower systemic burden, and a strategy that is built around the nail problem instead of the liver problem. Now, let's be precise. When people talk about carrier oils, the real value is not that the oil is itself a fungus killer. The value is that a well-designed vehicle may help the active ingredients stay where they are placed, spread evenly, and work as part of a local routine. That is a delivery concept, not a cure claim. The medical literature supports the importance of delivery and penetration. It does not support pretending that any oil by itself can erase a stubborn nail infection overnight. So if someone is using a premium botanical adjunct like a thoughtfully formulated essential oil protocol, the smartest way to think about it is this. Support the local environment, respect the barrier, and do not confuse natural with proven. For many people, the best results come from a layered approach that may include clinician-guided thinning, careful topical use, and patience while the nail grows out over time. That is the biological fix. Not force, but access. And for anyone with diabetes, neuropathy, or reduced circulation, this is not the chapter to become aggressive with files, clippers, or home debridement. The American Academy of Dermatology warns against trying to scrape or abrade nails at home, and the CDC emphasizes careful foot care because injuries can become serious. Safety first, always. Final grounding thought for this chapter. You do not need to overwhelm your body to treat a local problem. Understand the keratin shield. Use a delivery strategy that respects the barrier, and move step by step with medical guidance when risk factors are present. Now let's bring this home. You do not need to risk your internal organs to respect a problem that started in the nail unit. The biology is simple, even if the experience is frustrating. The nail is a dense keratin barrier. Topicals struggle to penetrate it, and oral terbinafine is a monitored systemic drug with liver warnings that require real medical oversight. Once you understand those three facts, the panic starts to quiet down and the next decision gets clearer. That is why a lot of people are looking for a gentler local strategy. Not because they want to ignore medicine, but because they want a localized routine that respects the barrier instead of shocking the whole body. The American Academy of Dermatology still emphasizes that treatment must penetrate the nail, and that the nail may need to be thinned for topicals to work better. So the most honest way to think about a botanical adjunct is as support for delivery and consistency, not as magic. If you choose a premium botanical protocol, the smartest mindset is humility. Use it as part of a disciplined local routine, Keep expectations realistic, and make safety the priority. Tea tree and other botanical ingredients have been explored, but the dermatology literature remains cautious and says the evidence is still limited. That is exactly why this conversation matters. You deserve something that is calm, local, and biologically rational, not hype dressed up as hope. And for anyone listening who has diabetes, neuropathy, poor circulation, or a history of foot wounds, the ending is simple. Do not become aggressive at home. The CDC warns that diabetes can reduce blood flow and damage nerves, which raises the risk of infection and serious foot problems, and it advises seeing a foot doctor promptly when symptoms appear. That is not fearmongering. That is respect for risk. So here is the final grounded thought. Understand the keratin barrier, choose your treatment path with your clinician, and never confuse a serious systemic pill with a simple cosmetic fix. Healthy nails grow out from healthy tissue, over time, with the right strategy and the right level of caution. Check the link in the description for the premium botanical penetrating blueprint. And remember, this video is for education only. If you are diabetic, neuropathic, immunocompromised, or you have circulation problems, do not self-treat aggressively or file your own nails. Get care from a podiatrist or healthcare provider.